So please start.
Hello, good evening. I'm Dr. Anil Kumar BT. I'm a nephrologist who is working in BGS Gleneagles Global Hospital. So it is nice to meet you all through this virtual media. So today I'm going to talk about the journey of a patient with kidney disease, and I just want you all to know that how what are the common causes of types of kidney disease, what is chronic kidney disease, what are the how one gets chronic kidney disease, and what are the symptoms, what are the complications of chronic kidney disease, and how do you manage these patients of chronic kidney disease actually. So first and foremost, we all think that all kidney diseases are same. It is not that. The kidney diseases means any disease which affects the uro genital tract is still called as a kidney disease. So it may be related to the function of the kidney function that we tell chronic kidney disease. So kidney, there may be stones in the kidneys. We also tell in medical terms renal calculi. So the filters may not be working properly, but the function is will be normal. There may be protein leakage in the urine, so we call them as glomerulonephritis. So in that there is nephrotic syndrome and nephritic syndrome, and there may be cysts in the kidney disease. There may be simple cyst or there may be some hereditary cyst. We tell them as polycystic kidney disease. So it is usually hereditary and it will eventually cause kidney failure. So infections of the urinary tract, we tell urinary tract infections. The infections may be at the level of kidney or it may be level of the ureter or urinary bladder. So depending on what level is there, we will tell as cystitis, pyelonephritis, urethritis. And there are some other congenital or hereditary kidney disease. Some may we may see even in small children, or we can present very late in the life. So coming to what are the functions of the kidney actually. The kidneys, first and foremost, what things all of us know, you all know this, it filters the blood and removes the whatever extra water is there. It is removing the extra waste from the body, and also it is keeping the body water in a balance actually. So that is the main function of the kidney actually. In addition, it also does some other functions, like it keeps the bones healthy. So it forms, kidney is a place where it synthesizes one hormone called as erythropoietin. So because of that, red blood cells are produced in the body, and we have a normal hemoglobin in the body actually. It also produces another hormone called as vitamin D actually. So this vitamin D active form is produced in the kidney. So that when what does vitamin do? It absorbs calcium and phosphorus from the intestine and keeps our bones healthy. So these are the other functions of the kidney, which is very very important. It is not only removing the waste from the body, it also keeps the water body in balance and also produces other hormones to keep the normal hemoglobin levels, and also keeps the bones healthy. So our main topic is about kidney failure. So what is kidney failure? Kidney failure, people most commonly when the patients come to us, they ask couple of questions, whether it is reversible, sir, or irreversible. So whether it is one kidney affected, sir, or it is whether both the kidneys are affected. So whenever we talk about kidney failure, so the reversible part of kidney failures are usually temporary kidney failures or acute kidney failures. Usually there is some possible causes, like so you may have a trauma, or it may be some acute intoxications, or there may be some or like some multi-organ part of multi-organ failure, like the patient may be admitted with COVID-19 infection or dengue, malaria, or some other bacterial infection, pneumonia, and is in ICU. So he may develop a kidney failure, and that is always reversible in most of the situations. Or it may be some specific infections until to the kidney. It may be a urinary tract infection and kidney failure. It will improve actually. So usually kidney failure improves within hours to days. By the most of the kidney failures, by the end of 2 weeks to maximum up to 4 weeks, they'll become normal. So whereas chronic infections, chronic kidney failure, so where the possible causes are diabetes, hypertension, some glomerulonephritis, some cystic kidney disease. Here the kidney failure will progress. It will not get cured. It will get progress over months to years actually, and it progresses over stages actually. And one or other day it will reach a end stage. So, chronic kidney disease, what are the common causes? As I earlier told, the most common cause is diabetes. Next is high blood pressure. The third thing is chronic glomerulonephritis. So, these are inflammations which is limited only to the kidney. Other part of the body will be normal. And there may be other diseases like in India, we have some of the places like in parts of Andhra Pradesh or in parts of the Punjab and this thing. So there we have diseases which were called CKD of unknown origin, where there is no cause at all actually, and then some 5% it may be because of hereditary causes actually. So the most common cause in earlier days it was chronic glomerulonephritis in India. Nowadays, diabetes, because diabetes is increasing in India, and in 2030, India is going to become the number one country where we got maximum diabetic patients. So diabetic has become the most common cause of chronic kidney disease. And who are at risk? Whether all the patients are at risk of developing CKD? Like which are the patients we should concentrate more? Whom we tell that you should be careful, you should screen yourself to know whether you are chronic kidney disease, are patients with diabetes, with high blood pressure, those who have got heart disease, those who are obese, means those who are body mass index is more than 28 or something, and those who have got a family history of chronic kidney disease. So usually there are some diseases which runs in the family. Not all kidney diseases runs in the family. There are some diseases which runs in the family. So if at all you have a family history of kidney disease, you need to screen yourself. Age more than 60 years, so they are more propensity to develop chronic kidney disease, and chronic smoking. So all these are diseases, risk factors to develop chronic kidney disease. And if at all you have any of these risk factors, so how to know that you are suffering from chronic kidney disease? Two simple tests we can do. So one is you can do a urine test for protein. Albumin is there, whether albumin is there in the urine. So we tell some test called as a urine albumin to creatinine ratio. That is one test. Or we also earlier used to tell urine for microalbuminuria. And another test is most commonly done is called as serum creatinine test. By doing these two tests, if at all you have any of the risk factors like diabetes, hypertension, heart disease, age more than 60, you're obese, and if you do any of these two tests actually, so we can come to know whether you are suffering from chronic kidney disease at a very early part of the chronic kidney disease. So after knowing like what is chronic kidney disease and how to test for chronic kidney disease, so the next is this is like what are the stages? There are 5 stages of chronic kidney disease. We do the staging depending upon the percentage of the kidney function. So we tell in medical terms as GFR. What is GFR? Glomerular filtration rate. If it is more than, sorry, if it is more than 90, we tell stage 1, 60 to 90 stage 2, 30 to 60 stage 3. In that there is 3A and 3B. And stage 4 is between 15 to 30, and stage 5 so is less than 15. So if it is reaches a stage where this kidneys are reaches a stage where it cannot meet the body demands, we tell end stage chronic CKD, end stage kidney disease, or end stage renal disease. So what is important is in the early part of this kidney disease, one may not have any symptoms actually. That is a, drawback of this disease, because if you have any of the symptoms in the early part of the disease, what we will do, we will go to the doctor early and get treated. And at times, if you go very very early, we can as well reverse it. Unfortunately, we cannot detect this kidney disease in majority of the patients. So the symptoms and signs will come usually in the later part of the disease, usually when they reach stage 5 or stage 4. So, so during this time, the common symptoms are swelling of the feet, are usually around the eyes or ankles, sleeping difficulties, and you pass more urine at the night time. We tell nocturia. Patients will be having itching all over the body. They have some frothy urine with we tell there some metal bubbles in the urine. Our urinary output may get decreased actually, and there also there may be generalized weakness like tiredness. All those things will get, and also there is a vomiting sensation, nausea or vomiting. So if any of these symptoms are there, you could be having chronic kidney disease. So what is more important is during this course of this chronic kidney disease, so patient may develop lot of complications, which I'm going to let you know. So what are the complications patient with chronic kidney disease may develop? So he may have low hemoglobin, that is called as anemia. His bones may become weak, we tell mineral and bone disorder, CKD, MBD we tell. Acid levels, because the kidney has got a capacity of keeping the acid levels in the optimal level. So when the kidney is not functioning, acid levels will fall down. So if it falls down, what will happen? It affects the heart. So it also, there may be some more risk for infections, and that is the reason most of the kidney patients, what we do is we give them immunization. And also patients with chronic kidney disease, because of the kidney disease itself, so patients will get malnourished, their nutrition becomes very poor. And also when you come to a doctor, the doctor will give you lot of restrictions like salt restriction, protein restriction, and because of this also they will be devoid of lot of essential nutrients. So that because of that also the patient becomes malnourished. And also there is a high risk of cardiovascular disease. Patients with chronic kidney disease usually die of complications because of cardiovascular disease. Actually. So coming to anemia, why you develop anemia is because the kidney produces an hormone called EPO, that is erythropoietin. So this hormone will act on the bones to produce RBCs, that is red blood cells. So that is how we have a normal hemoglobin. And if the hemoglobin is low in the body, if there is anemia, so one develops heart failure. So anemia, heart failure, and kidney failure all are interlinked actually. So another thing is heart disease. So as I told earlier, the most common cause of death in chronic kidney disease patients is because of heart disease or heart failure. So in the early stages, patients with CKD have got two times higher risk of dying from cardiovascular death. But in the later CKDs, so when you reach a stage of dialysis, it is 20-fold high risk. It means 20 times the risk of dying of cardiovascular death is known in patients with dialysis. So common is heart disease in CKD patients. The next is bone disease. Why bone disease happens in kidney failure is the kidney produces an hormone called as vitamin D. All of us know vitamin D, all of us do in our master health checkups vitamin D. Where is this vitamin D formed? It is active vitamin D is synthesized in the kidney. So what does this vitamin do? It absorbs calcium and phosphorus in the intestine. So whenever there is low vitamin D, so the calcium levels in the body is decreased. So what this low calcium will do? There is an hormone in the front of the neck called as parathyroid gland. Actually, this is the parathyroid gland. So when there is low calcium, it will sense this parathyroid senses this low calcium, and there is an hormone called as PTH, parathyroid hormone. This is secreted. What this will do? This will act on the bone, and it will remove the calcium from the bone and keep the body calcium level normal. So because of this, the bones becomes weak. So we tell renal osteodystrophy, and these are the patients are very high risk for fracture. So easily they will develop if they fall from a small height. So there is a high risk of fracture actually. And also patients with high PTH levels, they have got lot of cardiovascular complications as well. So once again, CKD is interlinked to bone. CKD MBD is linked to vascular calcification and cardiovascular disease. This earlier I had told patients with CKD, they have got lot of protein energy wasting because of loss of kidney function. There is decreased nutrient intake because associated diabetes, cardiovascular disease, that also will decrease food intake. And because in dialysis patients there is lot of catabolism happens, that will also causes protein energy wasting. All these things together consequences because of protein energy wasting. There is high risk of infection, heart diseases, and also the patients are usually very weak, we tell frail, so they need support to walking, and they're also depressed because of protein energy malnutrition. And it is so high, so you can't imagine. So by the time they reach a dialysis, up to 75% of patients are malnourished, or they have protein energy wasting. So common is the malnutrition in patients in CKD, especially in dialysis patients. So, lastly, what is end stage disease? We always hear this word ESRD or end stage. It is a stage where the person's kidney stops functioning permanently and needing either long term dialysis or a kidney transplantation. Until the patient reaches end stage, we can manage with a proper diet and with medications to treat the complications. But once you reach end stage, that is when the GFR falls less than 10 or 5, and that is a stage where the medicines do not act, and even whatever diet you do, so you can't reverse this kidney disease, and you have to plan of dialysis or transplantation. The planning will not happen when you reach the end stage disease. The planning has to happen when you are in fourth stage or third stage itself. So what will you do when you reach end stage kidney disease? So people always come and ask, when should I start dialysis? Whether the creatinine is 9, 10, or when is that? So the dialysis is started whenever you have a severe fatigue, severe tiredness. There is loss of appetite, eating less, nausea, vomiting. Their skin is itching. There is a lot of swelling in the hands, feet. Means there is signs of fluid overload. You feel a sensation of cold in the body. Sometimes you faint or you're dizzy. So, and if there is any breathing difficulty, these are the stages where one needs to consider dialysis stage whenever the creatinine is high. It's not depending on one creatinine level. But there are some conditions where whatever the creatine level, you have to do emergency dialysis. That is severely fluid overload. If your serum potassium in the body is more than 6, there is severe metabolic acidosis. Acidosis means the acid levels in the body increases, and there is uh, water collecting around the heart. We tell pericarditis, and then the patient is very confused, very, very drowsy. This is the stage where you have to emergency consider dialysis. Coming to dialysis, we have two types of dialysis. All of us know hemodialysis, that is sometimes in layman's term we tell blood dialysis, or peritoneal dialysis, where a tube is put into the abdomen and the fluid exchanges takes place. So hemodialysis, what exactly happens is, this is a patient who is lying on a bed in a dialysis room. The blood will go from in this black line, it will go through, and it is pumped by a blood pump, which will pump to the filter. We tell this filter also as a dialyzer, and it will come out of the filter and comes back to the body. And in this filter, the dialysis fluid also goes in a opposite direction. Blood goes in this direction, dialysate fluid will go in the opposite direction, and whatever waste is there, it comes out through this outlet of this dialyzer fluid into another waste outlet actually. So here all what happens, the blood is coming out like this in this direction, the fresh dialysate fluid is coming in this direction. Here there exchanges takes place in the filter here actually, and the waste material will come out. So this session of this is around 4 hours. During this 4 hours, the whatever waste is there in the blood will come to the dialysate fluid, and whatever good new substances or white electrolytes are there will go to the blood actually. This is how the exchange takes place, and that's how dialysis happens actually. So dialysis is usually done 2 or 3 times a week. The standard is 3 times a week. Each session lasts for 4 to 4 hours. Whatever fluid gained in between dialysis is removed during dialysis. Additional medicines we have to still give. Not dialysis is not enough for kidney failure. We have to give medicines to improve the hemoglobin, erythropoietin or darbepoietin. So, and to improve the bone disease, we give some calcium, reduce the phosphorus, we give phosphate binders, and also BP medications or diabetes medicines will be given. The common complications in dialysis includes low blood pressure. Because of that, cramps may come. Sometimes when you have a catheter and all in the body, you may get infections. These are the common complications we get on dialysis. Dialysis is usually done either through a temporary access. We tell either a jugular catheter or a tunneled catheter where the tunnel is done here and the catheter comes at this level, or you have a fistula where this artery and vein they are connected. So you don't keep a machine here or anything, only the artery and vein are connected. This we tell a AV fistula. Coming to peritoneal dialysis, what we do is there is a catheter put inside the abdomen by a laparoscopic procedure, or manually we can put. So the catheter comes out, and this is a transfer set, what we tell. So, and this is a titanium adapter. So this can be folded and kept in a pouch like this. This is how this catheter is kept in a pouch stylishly, and he can walk around with this catheter actually. So how does the peritoneal? This is how a patient is sitting on a chair and doing a peritoneal dialysis. There are two bags here. This is a bag filled with the peritoneal dialysis fluid. This is a bag which is a empty bag. So the fluid comes from here to the abdomen, and there is a lock here, and this lock is closed, and he can walk around. After 4 hours or 5 hours, he can connect this lock once again. Means connect it, and the fluid, whatever dialysis set which has happened, which will come out through this tube to the empty bag actually. So this is how a peritoneal dialysis. So during this time, where 4 hours I told, we tell dwell time, and this normally to fluid to go, it will take around 10 minutes. To come out, it will take around 20 minutes. Inside the abdomen, we keep around 3 hours or 4 hours, depending on the doctor's advice. So each day we do around 3 cycles or 4 cycles. This is another form of peritoneal dialysis. We tell APD or automated peritoneal dialysis. So this is called as CAPD, and this is called as APD. Here we can put a 10-liter bag on this machine, and you connect it to only once, and you can set it where the machine itself will do 5 6 cycles or 8 to 10 cycles in the night time. The patient is happily sleeping here, and this does automatically. So this is called as automated peritoneal, nothing to do manually here actually. So this is how different cycles looks. In APD, we can do night cycles alone. Daytime, we can do whatever you want. Or daytime also 1 cycle, and night we can do 4 5 cycles. In manual, we have to do 3 or 4 cycles in a day. So lastly, so what is the two options I told? One is a dialysis, and another option is transplantation. Which is best? Dialysis is better or transplantation? Definitely transplantation is better. I will later on tell you what are the advantages of transplantation. So what you do is the donor's kidney is harvested from the donor, and it is attached to the recipient, the kidney failure's body, where it is attached to the blood vessels which are going to the leg. So usually the right leg actually. So the blood vessels which are going to the right leg, there you attach the donor's kidney here actually. Okay. So and the patients will be your dialyzing actually. So, what are the benefits of kidney transplantation? The most kidney transplantation lives longer. Most patients enjoy a better quality of life, no longer to need dialysis, higher energy levels, their work and travel is very easy, and fewer restrictions. Like you don't have to do a lot of restrictions as we do on dialysis. You can eat whatever you want actually, and drink how much you want fluids actually. So that is very very important. So mostly they will, the females, they can still have children, and they, if they are going to office, they can regularly go to their office. So normally when you see a patient after a kidney transplant, no, usually they don't look like a patient, they look like a normal person. And lastly, their sexual life is improved, and also as I told, they can conceive, the females can conceive, they can have children. So all these are advantages of kidney transplantation. So the most common question is who can be donors? There may be living donor transplantation and cadaver transplantation. Cadaver is also called as diseased donor transplantation, where the in at birth only you can give a consent, or when you are brain dead, means because of accident or for some stroke. So when you are brain dead, so the family can give a consent on your behalf and tell that they are willing to donate his or her organs to the allocation team. So if you are registered for this one, and after your waiting time is high on the way, so you will get this organ. This is called as deceased donor transplantation. In living donor transplantation, usually in India, it is the first degree relative, either mother, father, brother, sisters, or wife or children donate the kidneys. So usually one kidney is donated, and they donate. The normally the donor will don't have any problems during their life, because they are always healthy people who donate, and their workup is done before transplantation. Only if they are healthy, their kidney is considered to be donated. So usually, so throughout their life, they don't have any problems actually. Normally, the success rate is slightly better in living donor transplant, about 98.1%. In cadaver, it is around 95% actually. So, what are the different types of transplant? Normally, earlier it was like O donor can donate to A, B, or AB, means he is a universal donor. AB can receive from everyone, so he is called as universal recipient. A can either receive kidney from either O or A itself. B can receive kidney from O or B itself. But now things have changed. We can do ABO incompatible transplantation as well, where any blood group donor can donate to anyone. So in our center in BGS Global Hospital, we have done the maximum ABO incompatible transplants in Karnataka. So this is also a possibility whoever doesn't have a donor. And lastly, the swab transplantation or paired exchange. Say, for example, you have a patient like donor one who is A positive and the recipient is B positive, where it is difficult. But you have a donor with B and A recipient, we can do something called as exchange. So this donor will give to that recipient, and this donor will give to this recipient. So mutually, both are benefited here, so that we call it as a swap transplantation or a paired exchange transplantation. So finally, this last two slides I want to tell. So I have told about the journey of a patient with kidney disease, how one has got a risk factor, will develop a kidney disease. He progresses from stage 1 to stage 5. When he reaches stage 5, he has got only two options of dialysis and transplantation. So he has to choose between dialysis or transplantation. The best option is transplantation. So even in India, what happens is out of 100 people who need dialysis or transplantation, only 10% will be fortunate to get it. Majority either die on dialysis, so or they develop of some other complications of transplantation. So our aim should be not more than treatment of these patients. Our aim is to prevent this disease, because this CKD is a deadly burden, and it is the fifth commonest disease to cause death in our population. So the where is the prevention takes place? There is primary prevention, secondary prevention, and tertiary prevention. Primary is at a stage where you don't have diabetes or hypertension. That is a stage where you do primary prevention. Secondary prevention is a stage where you have got diabetes, hypertension, and you So what you need to do is we need to see that they reverse to developing chronic kidney disease. So this can happen at very early stage where they are just diabetic and hypertension. So secondary prevention is, first we need, if at all they are diabetic, hypertensive, family history, obesity. So you need to screen these risk factors, as I earlier told, by doing two simple tests actually. One is you do a urinary albumin creatinine ratio. Second is you do serum creatinine. So once you screen them, so you there are a lot of drugs, so where we can treat them. So with the medicines to control their diabetes, blood pressure, and proteinuria reducing medicines to reverse this disease. So the tertiary prevention is controlled to see how to control blood pressure, and already they are developed a CKD. We have to just slow down the disease, but eventually they will develop end stage disease. Even if your creatinine is 1.5 or 2, one or other day they will reach end stage disease. So nobody can stop this disease. So we need to concentrate more on the risk factors of chronic kidney disease and tackle at this point, because once you already develop, it is very difficult. So with this, I am going to conclude my presentation. Thank you. Every year we have this World Kidney Days. There is a theme actually. So this theme is you have to support the vulnerable person, and we have to prepare for the unexpected. Like during COVID times, majority of them lost their lives. Patients with kidney with dialysis patients could not get dialysis. Those who are in transplant could not get medicines actually. So you need to prepare for this, all these medicines. I say my patients, keep 1 month medications ready. So keep always a plan B. What happens if this fails? What else to do? So you have to prepare yourself. And those who don't have kidney disease, who want to know what things you have to do to keep your kidneys healthy. So one, you have to be fit and active, work out 4 to 5 days in a week, monitor your blood pressure daily. See if whenever your blood pressure is more than 140/90, go to a doctor and consult him to ask him whether you have chronic kidney disease. Drink at least 8 glasses of water per day, and eat lots of fruits and vegetables. Do not smoke. Keep a healthy weight. Obesity is also a major cause of kidney disease, not only kidney disease, liver disease, heart disease. So you need to keep your body mass index less than 25. Do not take over the counter medications. People have a habit, you have a headache, go to the medical shop and taking some painkillers or antibiotics directly, and the shopkeeper also gives it. Actually, there's the sad part. And there are some of the medicines which may cause kidney disease. And ask your doctor to check your kidneys if you have diabetes, hypertension, or overweight, or family history of kidney disease. So with this, I want to thank you for a patient hearing, and I'm happy if at all you have any questions to me to be asked. Thank you. Any questions? Thank you.